So my favourite down the microscope is menstrual phase, which is this, I think, just describes what happens to a woman in the menstruation. The glands are exhausted and they just look exhausted, and you get balling up of the stroma. It's just curled up into a ball and it's given up all hope. And you get these fibrin thrombi, which is plugging of the vessels by little balls of coagulation, essentially. And then you get the hemorrhage that goes on as well. So that's what we see in menstrual phase. And then it starts again, goes back to the beginning.
I think I want to get a picture of an exhausted endometrium to put on a T-shirt, because don't we all feel like that sometimes?
I could send you, I've got like so many photos of pathology on my phone.
I would love that.
That's and you know, maybe there's some comfort in that our tissue's exhausted at that time as well. It's exhausted on so many levels, even at the microscopic level.
Hello and welcome to another episode of Endo Untangled. My name is Alicia Macro. I am a general practitioner with a special interest in women's health, and I'm joined by Cherie Noble, my co-host, who is an accredited exercise physiologist. And today we are joined by Dr Rebecca Morrow, who is an anatomical pathologist with a special interest in gynaecological pathology. Dr. Beck, welcome to the podcast.
Thank you. Thanks for having me.
Beck, we really wanted to get you onto the podcast because here we are looking at endometriosis through all types of different lenses. And it made sense to me to start looking down the microscope lens, perhaps, at endometriosis. Endo is a very complex condition, so is pelvic pain. And I think that this is an area where, to me, there's a lot of misinformation and misunderstanding about what pelvic pain and endometriosis actually is at a microscopic level. And we were really hoping to pick your brains on that. But before we get started, love to hear a little bit more about you in terms of what brought you into pathology to start with, and why gynaecological pathology as well.
Yeah, great question. I guess pathology for me is the intersection of two things I love, art and science. I'm a very visual person. The world down the microscope is a magical place. Not many people have the privilege of seeing that, but that's my daily job. And I guess the science side of it is that pathology really explains the basis of disease. And I think we're all very aware that most medical treatments are based on pathology results. So for me, I love the diagnostic chase of working out what the diagnosis is. I'm a very pattern-based problem-solving person, and it just gelled naturally with sort of my strengths. I was lucky enough to get an RMO rotation in pathology. I actually used it as a bargaining tool to get another rotation that I wanted. And I just loved it. And it was the rotation where my pager went once, and it was for a coffee call, as opposed to the daily slaughter of every other rotation. And pathology really is one of the best kept secrets as a medical specialty, although judging by the pool of people that are now trying to enter the program, I think the secret's out.
Look, and I think you're right, it is a well-kept secret in terms of even me as a medical student, and I've talked about this before, I started medicine into my 20s. I was in my mid-20s, and I really came into it without a good understanding about what pathology is and what pathologists do. Could you tell us a bit about what your day-to-day life looks like as an anatomical pathologist, particularly with your interest, not just in gynae, I know you're interested in head and neck pathology as well, but what does that look like? What are you doing there in the lab?
Yeah, that's a great question. So I guess the mainstay of what we do is look down a microscope and interpret the tissue that's on the slide, write a report that then goes back to the person that sent us the biopsy or the resection. That would probably be maybe 60-70% of what we do. Another good chunk of what we do is presenting those cases at multidisciplinary team meetings where you've got radiology, pathology, the oncologies as specialties, the surgeons, and discussing, they're usually cancer patients. They're bringing everybody together with their expertise and coming up with a plan to move forwards for those patients. We as pathologists do autopsies as well. So part of my role at the Royal Adelaide is helping to service the hospital autopsy service. So had one of those in my week last week. We also, the other big side of pathology is the macroscopic assessment of large resection specimens. That is mostly delegated to our registrars and our technical grossers, but that's still a big part of what we do. So describing the specimens that come in, taking sections from certain areas that translates to what we see down the microscope. I also do a lot of work in quality. Part of my job as deputy head is making sure that we have systems that are in place that ensure that the tests are validated and that what we're doing is meeting certain benchmarks. Yeah, it's a varied job. Every day is different. I also have a part of my role that's a volunteer job that I go out and assess other laboratories to ensure that they're meeting standards that are set across the board for pathology laboratories. So, yeah, every day is different. You can never quite predict what's going to come in, but I guess the mainstay of it is translating the tissue that comes in into a report that goes back to GPs or surgeons so that they know what they're treating.
That is just such an important foundation of what our modern health system is based on. So, so thank you so much for that work. And also thank you so much for giving up your time and coming, using a different part of your brain today to talk to us. And what I'm hoping to start with today is to actually talk about what we think the causes of endometriosis might be, and what we learn about in medical school, and what I imagine a lot of the foundation for you is based on is what we call the pathophysiology. So what's actually happening when things are going wrong in the body, causing illness. Can you talk us through the different theories about where endometriosis actually comes from?
Yeah, sure. I guess there's two main theories in the pathology literature. The first is what they call retrograde menstruation. So shedding of the endometrium up through the tubes, which is an open system because the tubes have these little fingers on the end called fimbriae. They're designed to catch the egg as it ovulates and travel down the tube. But you can imagine it's a two-way street. So you can have your endometrium and stroma traveling back up the tube and, floating free in the peritoneal cavity. So that's the first theory of where it comes from. Another theory is that it's possibly hematogenous, so enters the bloodstream and then, travels around and lodges in the peritoneal cavity. I think one of the other theories that I've read as well is that there's embryological remnants in the peritoneal cavity along the tracks where things form in embryological terms, that we see those remnants in other organ systems as well, but there's what we call Müllerian remnants from the formation of the gynaecological tract that pop up in random places. So, yeah, those are the three main ones that I'm aware of.
And based on what you see under the microscope, do you have any thoughts, or are there any thoughts in the literature about what might be the most likely cause, or do you think there might be actually different types of endometriosis that we find that actually have different causes?
Great question. I guess I can't really comment on cause based on what we see, in that it all looks the same. So the diagnostic criteria for endometriosis is essentially endometrial tissue outside of the endometrial cavity. So endometrial tissue is made up of two main components, the epithelium or the glands, and the stroma, which is the mesenchymal component that the glands sit within. So when we're diagnosing endometriosis, we're looking for those two things outside the endometrial cavity. And if patients have both of those things, it's a definitive diagnosis of endometriosis. There is a third criteria as well, which is hemorrhage or evidence of prior hemorrhage. So if they have just one of those things, then they might get a report back that says suggestive of endometriosis as opposed to a definitive diagnosis of endometriosis. So I think morphologically, it all looks the same. It all looks like glands and stroma, be it superficial, be it deep within tissue, no matter where it is. I guess to investigate that question, potentially you could be looking at protein expression of endometriosis in different locations. I'm actually involved with a research team with my gynaecology counterparts, the surgeons, and some our research team over at the uni looking at proteomic expression in endometriosis, utopic endometrium, and tumours derived from endometriosis. It's early days, so can't give you any data on that yet, but that, I suppose, would be one way of looking at are there different types of endometriosis? Do they have different protein expression that could lead you to a theory of different pathophysiology and, origin?
So that brings me on to another question, which is endometriosis has a lot of discussion around it, and a lot of it is very passionate. And one of the things that people will say is that the tissue of endometriosis is not the same as what's in the endometrium. It's endometrial-like tissue, which is found outside of the endometrium. What do you think about that as a pathologist? Is that, or does it all look the same to you under the microscope?
whether it's endometrial-like tissue or endometrial tissue, it looks the same and stains the same and responds the same way to hormones. And so from a functional perspective, if you think about your cycling endometrium, shedding of endometrium, which, is quite a painful process as it is, produces blood. If you put that process into a peritoneal cavity that's exquisitely sensitive to blood, you can understand how you get intense pain from cycling endometrium outside of the realm of where it's, usually found, because no matter where it comes from, it looks like endometrium, it stains like endometrium, it cycles like endometrium, and we understand why it's producing the pain. Perhaps if it can help us understand how to better treat the disease, prevent the disease. I guess part of pathology, like you say, is understanding the pathogenesis of disease, and that sort of goes back into the research aspect of my job, which is trying to further the field of pathology and understand, test theories and use the latest technologies available to us to try and better understand disease process. So we're looking at that endometriosis and tumours derived in the context of endometriosis to better understand, are there actionable mutations perhaps in these women that we could be putting forward for targetable treatments, or are there different risk types of endometriosis? Like, are there high risk types and low risk types? So I suppose it is helpful in understanding what it could mean prognostically and treatment wise, but at where we're standing at the moment in terms of the day-to-day impact.
And how we might treat it as well.
How we might treat it.
Could you take us through the different types of endometriosis? We have talked about this briefly in other episodes, but the different types in terms of deep and superficial, and also the endometrioma.
Yeah, so I suppose from a pathologist perspective, it's all endometriosis, but what we're talking about is where it's found. So we can see endometriosis just in the superficial aspects of the peritoneal cavity. We can see it embedded deeply within tissue. So it can be so deep that it can present as a polyp in the colon, for example. So it's all the way through the wall and onto the mucosal surface. So it can be deeply embedded. What we see down the microscope is the same from those superficial to deep. The other most common place that we see endometriosis is in the ovary, and one term used is an endometrioma, but for us that just means a cystic space that is endometriosis derived. So from my perspective, could they all be different types? Possibly. Do we see the same thing down the microscope? Yes, just in different locations.
And so the difference between, say, superficial and deep endometriosis, I understand that the deep one is burrowing and it's starting to make its way into a tissue. Do you think they're different? There are different parts of their evolution. Does something start as a superficial and then start to burrow or become deep, or does it just depend on where it's found itself in terms of, does it have tissue to dig into? Do you have any thoughts on that?
Yeah, that's an interesting theory. I suppose that's one explanation for going from superficial to deep, or is it, we're in theory land here, or is it that, one of them is hematogenously spread and so ends up in deep tissue at the outright as opposed to burrowing in, or are they indeed different types of endometriosis? I think there's a lot of questions and a lot of answers at present with that.
And so what do you see under the microscope in terms of impacts in the pelvis, like in terms of adhesions of tissue stuck together, nerve involvement, blood vessel involvement? What do you see in some of those cases?
Yeah, so beyond the diagnostic kind of tissue that we see, the glands and the stroma, the third most common thing that we see is evidence of hemorrhage. So extravasation of red cells, that just means red cells outside the vessels. We often see hemosiderin-laden macrophages, so they're the inflammatory cells that mop up the mess, and that's the old blood inside the macrophages. And we always, pretty well always, it's dangerous to say always and never, but I can't think of a case of endometriosis where I haven't seen associated inflammation. And often actually you see the inflammation before the endometriosis. So some of the biopsies we get through, you might not have the diagnostic glands or stroma in your initial level, but you'll see a bit of inflammation, cut a bit deeper, you might find your diagnostic criteria of endometriosis. So there's a few other reactionary things that we see. So often there can be a mesothelial kind of mopping up and reaction to that process. Sometimes we see mesothelial inclusion cysts. Sometimes we see adhesions. I'm trying to think of whether I've seen vascular involvement and perineural involvement from endometriosis. It's not something that I would say it's not something that I say, yep, see that all the time.
So when you say vascular involvement or perineural, the endometriosis sort of digging into or burrowing into vessels and nerves? Is that what you mean?
So they're terms that we more commonly use with malignant processes. So when a tumour invades a vessel or a tumour wraps itself around a nerve, that's not really something that I see common. That's not something I associate with endometriosis in my routine diagnostic practice. More so it's the inflammation and the adhesions and the peritoneal inclusion cysts that we see.
So I was just listening to just the complexity of what you do, which is fascinating. When you're talking about whether you see endometriosis or not, but you see inflammation, is that where you would get reports that potentially you don't come up with a diagnosis of endometriosis, but are you seeing some things that indicate, how we could explain pelvic pain, for instance, without endometriosis, or is that a precursor?
Good question. I think endometriosis or biopsies for endometriosis are a very common part of my workload. They often come with uterine curettings as well. I guess my first comment would be there's so many different causes of pelvic pain, and like you said, it's a really complex field. So that's my first thought. There's many causes of pelvic pain. My second thought is we're at the mercy of what the surgeon sends us. So if they don't biopsy, it's not on my slide, and I can't give you a report based on what is not sent to us. And that's something that you always have to consider. And I suppose that would be over to my laparoscopic colleagues to comment on how easy or hard it is to identify endometriosis and biopsy it successfully. I quite frequently see patients who have had a diagnosis of endometriosis tissue confirmed. They've had subsequent biopsies and there's not a lot to see. So there's the possibility of treatment effect. The reports I put out based on those diagnostic criteria, sometimes we just see the inflammation and nothing else, no matter what we do. Those reports go out as minor changes. Now, there's still inflammation there. That's still going to be painful, but there's no diagnostic criteria of endometriosis. So that would be the first category of reports that go out. The second would be suggestive of endometriosis, where you have one of those features of endometriosis, but you don't have enough to definitively call it. And the last type is the definitive diagnosis, where you have two of your three diagnostic criteria and you can be definitive about it. So, yeah, that's how we kind of go about thinking about structuring those reports and what we need, what diagnostic criteria we need to be definitive about diagnosing endometriosis.
And I'm just curious, I'm not sure how easily you'll be able to answer this, but as a proportion of samples that you get sent from laparoscopy where endometriosis is being looked for or suspected, what's the sort of hit rate for finding endometriosis? Is it sort of 50-50 that you might see it there coming from a laparoscopy? Is it more common? Is it less common to actually see it?
Oh, good question. Often we get multiple biopsies from the same patient. So if I think about it in that regards, like within that, you say you get a biopsy series of four biopsies, it's pretty common that at least one of those biopsies will have diagnostic features of endometriosis. But I would say it's uncommon that all four have diagnostic features of endometriosis. When I think about how many reports anecdotally go out as minor changes, which is where you have the inflammation but no features of endometriosis versus a definitive diagnosis of endometriosis, I'd say more than half of what we see come through gets a definitive diagnosis of endometriosis. I'd have to run the numbers to kind of be more precise about that. But more often than not, I'm putting out reports confirming the diagnosis or at least suggestive of endometriosis. Yeah, I'd say it's less than half that get a report that we can't commit to even suggestive of endometriosis.
Okay. I'll tell you what I was thinking. Sheree and I occasionally run groups for pelvic pain and open the groups with patients, people who are suffering with pelvic pain, and open up for questions. And one of the most interesting questions that someone asked was, well, if endometriosis is something that is travelling through the body and is setting up in distant sites and those sorts of things, what makes it different from cancer? Like, how is it different from cancer? What is your thoughts on how it's different and how it's the same?
Yeah, that's a great question. Yeah. I suppose the Robbins, that's one of our sentinel textbooks, the Robbins definition of cancer is that it's a malignant neoplasm that's got The potential to metastasize, I suppose the definition there is malignant. So endometriosis is a benign condition. There's about a 1% chance, I think that's the quoted rate in the literature, 1% chance of malignant transformation. We see that most commonly in the endometriomas of ovary, but it has to undergo a malignant transformation before it is considered to be a cancer by that definition. So I suppose it can cause a lot of pain. It can cause a lot of local irritation, but it's not, in our current thinking, a malignant tumour that will metastasize and eventually lead to your demise.
The other question, I feel like I'm just firing questions at you, sorry, but it's just so many things that I would love to get your thoughts on is where endometriosis can be found. And there's a lot of interest. I get a lot of questions about distant symptoms. So someone who has pelvic pain, that they also commonly get headaches. They also commonly get thoracic pain. They get fatigue, all sorts of other symptoms, which we deal with a lot. How common is it to find extrapelvic endometriosis, so endometriosis found in distant sites like the brain or the lung? And also I've had people ask me if it is possible to find in people who are assigned male at birth.
Most commonly we see it peritoneal cavity and ovary, but there are a couple of other sites that aren't, I suppose, too uncommon. So surgical sites, the most common in females obviously being lac from from a Caesar scar. We had one last week that was in someone's umbilicus. That's another site that we see them. Pretty uncommon to see it outside of that in my experience. Does that mean it can't happen? No, but it just means that I'm not seeing it.
What's the most unexpected site you've seen it?
Probably the umbilicus.
Okay.
That was a bit of a highlight for us. Caused a bit of excitement. Yeah.
And just thinking about what excitement in the pathology lab looks like.
And if you ever wondered, that's what it is.
And you mentioned polyps that are found at colonoscopy, for example, that could possibly look like a polyp and actually be a spot of endometriosis.
Yep.
I imagine that would probably cause some interest in the lab as well. How often does that come about?
Well, if you're sitting your exams more often than it should in real life. But actually endometriosis is a classic exam question because it's a benign mimic of cancer.
Yeah.
So if you don't think about it and you can be led well down the garden path in sites that you don't think about endometriosis, and you've got these glands, they're where they shouldn't be, they can look stirred up. You can imagine how, without thinking about endometriosis, without it being on the radar, it can lead the pathologist down a very long path of trouble.
What could you mistake it for?
Cancer.
Okay. Cancer of the endometrium, or could it look like? Because
like any gland-forming cancer, endometriosis can be a mimic of.
Right.
Wow.
Okay. So, what other gland-forming cancers are there?
Oh wow! Name your organ and I'll give you one.
Okay, breast or.
I suppose I'm thinking most commonly along the gastrointestinal tract,
Right.
because the endometrial glands are columnar. They've got elongated, nuclei that can look similar to the glands in the gastrointestinal tract.
Because I think it's easy for someone like me as a GP who's not looking at the microscope at these things to sort of almost think that there's something really really obvious about tissue that you're looking at, that you could look at it and go, oh yes, that's definitely that's definitely endometrial tissue versus bowel tissue or whatever. But tissues can look like each other, can't they?
There's different histological features in different organ systems, but I think pathology. I think a lot of people think what we do is very black and white.
Yeah.
But actually, we're dealing with patients and disease spectrum. We're just like the rest of medicine, where there's shades of grey. So we talk about having an opinion. When someone sends me a case, they talk about it being for gynaecological opinion, and that's exactly what it is. It's my diagnostic opinion. It's not necessarily the right answer, although goodness, I hope it is for the patient's sake. But we make judgment calls on a daily basis, which is part of what makes our job so stressful, knowing that what we are diagnosing is what the patient's treatment is based on. And I mean, we always do our best, but we're humans, we're not machines.
Yeah.
We don't always get it right.
You do an amazing job with the information that you get. In terms of a report, so you've talked about the reporting process and what you're looking at and what goes back to the doctor that sent the tissue and often the GP like me. There's been a lot of news recently about sending off of pathology reports and whether or not women who are having laparoscopy or other gynaecological surgery are having enough of their report explained to them in terms of what the pathologist could see was sent to them. And I suspect as a GP, I'm going to be having more and more women come to me wanting me to source their reports or wanting to discuss their reports. Have you got any thoughts or advice for a woman with endometriosis or with pelvic pain who's had biopsies or for her GP? What sort of information should she be looking for or looking at when she's looking at her report?
I think this speaks to the fundamental question of pathology reports going straight to the patient. So there's a few complexities here. I do believe in knowledge is power, and I do support the general public having access to their health information, including their pathology reports. I think we have to balance that with the context in which they receive the information. So if you think about how scary the terminology has been that I'm using today, and you're both health trained professionals, you then put that into layman's context to try and negotiate a pathology report. We speak another language, really. Even sometimes when I'm trying to explain it to other health professionals, they kind of say in English, please. So our pathology reports are somewhat written in another language. And I do believe that patients are best suited to be guided through that by another health professional who understands that language. On that note, actually, our college has advocated for the 7-day delay for histopathology results, which I back 100%. So I think if you think about it from the patient's context, yes, we want them to have their health information, but I also desperately want them to be in a safe and supported environment when they're having that information explained to them. Having recently gone through the experience of having a biopsy myself, I think you'll know the anxiety of waiting for that result. And as humans, we're just in amygdala hijack in that situation. We are all emotion and zero intelligence, and even trying to access the medical part of my brain, waiting for those results, it's incredibly difficult. And what did I want? I wanted a doctor to call me to say, hey, everything's fine. The biopsy came back normal.
Yeah.
I didn't want to be accessing my own pathology result, and I'm a pathologist.
Yeah.
So I think we need to hold that in equal measure to health information freedom. So that's a very long way of saying I think these results should be delivered in a context where the patient and a health professional can go through the report together. What should the health professional be looking for? I think in the first instance, a definitive diagnosis of endometriosis. And we write our reports so that we put the conclusion at the top, because we all know that you don't read the body of the report. It's always a good day when you get a call from a clinician and said, I was just reading your report. You're like, hold the phone.
Oh, did you read the report?
Wow. In the bottom line, I'm like, wait, yeah, that is buried in the text. Well done, you. So there's a conclusion there. I think the second thing to be looking for whenever we report endometriosis, we're looking for atypical features. So like I said, there's a very small chance that these can progress to something more. So you want, as a health professional, to be ensuring that there's nothing that we would be reporting as atypical endometriosis or indeed a tumour arising from endometriosis. So there is the potential for surprises in histopathology results. We are the doctors that diagnose cancer. You never want to be reading that report alone without health professionals around you. So yeah, that would be my pitch for what to look for and in what context to look for it.
Yes, and I would say I wonder whether 7 days is enough, thinking about how long it can take to get a appointment with your trusted GP.
Yeah.
And I think it is a difficult pathway forward, really, and especially with how much everyone wants to put their health information or their report into ChatGPT or even Google, and we know how horrifically unhelpful that can be, especially if you're, as you say, you've got your amygdala taking over and you're not necessarily able to think through things, because the first thing I feel like Google or ChatGPT tells you is that it's terminal, and it's very high concern for people getting the wrong idea and
it's about making trusted sense of the information, isn't it?
Yeah.
Like without is probably a tangent, but I saw a post around, again, the risks of putting things in ChatGPT and Google, where a guy asked ChatGPT, one of the AIs, whether he should walk to the car wash or drive the car to the car wash, and the AI thought it was going to be quicker to walk to the car wash. That's a very simplistic answer, but it's like where it hasn't got that context of the world, and then if you translate into putting health information and the implications for this, it can be a bit scary. I think when we're talking about these complex reports and some of the terms that you used, Beck, earlier, I was sitting there going, I might have to look up what that means later as well.
There's also privacy implications of putting your health information into a publicly available AI.
Yeah, and where that goes as well, that information, and who owns it once 100%. You put it in there.
Yeah. I mean, putting aside the AI will hallucinate and lead you down the garden path on occasions.
Yeah. Yeah. Beck, I'm wondering, I'm really interested in what normal, well, for want of a better word, normal endometrium looks like. Can you talk us through that?
So endometrium is actually a moving beast because it is under the influence of hormones. So it goes through multiple phases. So starting from the beginning, it goes through proliferative phase. So that's when the glands are reproducing after having just gone through menstruation. So in that phase, we call it blue endometrium. So you get mitotic activity in the glands and in the stroma, and that is all very normal.
So it's dividing, mitosis, meaning it's dividing, it's proliferating, thickening.
That's right. It's thickening. It's doing its thing. And did
you say it looks blue?
Yeah, it looks blue.
On your stain?
Everything looks blue and pink down the microscope. Pink and purple. But it looks blue because there's less cytoplasm. We'll get to the cytoplasm in secretory. But yeah, everything's turning over a bit more quickly. And then we go to secretory phase, which is where it stops proliferating and it starts secreting. So the first thing we see in secretory phase is that the secretions actually form underneath the nucleus or at the basal aspect of the cell, and we get what we call subnuclear vacuoles. And then as it moves through secretory, those secretions move up. You get really open, pink-looking glands with a lot of cytoplasm and lots of secretions within those glands, and the stroma changes slightly as well. And then from secretory, we move to menstrual phase, which is...
And just before you move on to that, what's being, I'm sorry to sound dumb here, what's being secreted?
I suppose it is proteinaceous material that would support implantation of an embryo.
Yep.
Yeah.
Okay.
It's very busy.
It's very busy.
It's a very busy issue.
So my favourite down the microscope is menstrual phase, which is this, I think, just describes what happens to a woman in menstruation. The glands are exhausted and they just look exhausted, and you get balling up of the stroma. It's just curled up into a ball and it's given up all hope. And you get these fibrin thrombi, which is plugging of by little balls of coagulation, essentially. And then you get the hemorrhage that goes on as well. So that's what we see in menstrual phase. And then it starts again, goes back to the beginning.
I think I want to get a picture of an exhausted endometrium to put on a T-shirt, because don't we all feel like that sometimes?
I could send you, I've got like so many photos of pathology on my phone.
I would love that.
That's and maybe there's some comfort in that our tissue's exhausted at that time as well. It's exhausted on so many levels, even at the microscopic level. Let's have a little bit more compassion around our cycles and how we feel on the inside and out.
Dr. Rebecca Morrow, thank you so much for sharing your expertise with us today. So many new thoughts and ideas to take away from us. Absolutely. And an exhausted endometrium. We'll see you next time.
Thank you.
Bye.